Hey folks, welcome to the AABIP podcast. This is Samir Avasrala from Case Western Reserve University School of Medicine in Cleveland, Ohio. I'll be hosting this episode. Thank you for joining us. Today we'll discuss the relevance, or dare I say irrelevance, of R.O.S.E in 2025. I'm excited to have Dr. Brian Schaller join us. Brian is the director of the IP Fellowship and a clinical assistant professor of medicine at Stanford University. Brian, do you have any relevant conflict of interest to disclose?
I do not.
Wonderful. As a reminder, the views expressed on this podcast are those of the speaker in mind and not necessarily endorsed by the AABIP. With the formalities done, let's get started. All right, Brian, walk us through your process of using R.O.S.E at your shop for, let's say, a robotic bronchoscopy for a 17 or 20 millimeter nodule and a full staging EBUS. What do you do at your shop?
For sure. And first off, thank you so much for having me, and looking forward to having this discussion with you. I'll walk you through how I use R.O.S.E, and when I'm done, I'll tell you I'm done going through all the steps for how I use R.O.S.E. Okay.
Mm-hmm.
All right, I'm done. So we stopped using R.O.S.E around September of 2021, about a year after we started, or about 5 or 6 months after we stopped doing robotic assisted bronchoscopy, and nearly 2 years after we started using cone beam CT.
Okay.
Prior to that time, our standard workflow was to do R.O.S.E for all of our cases, whether it be peripheral nodules or staging EBUS. Over time, as we did more and more cone beam cases, we came to realize a few different factors. One was that we were not getting a positive call in the room nearly as often as we would hope to,
Sure.
Especially with our peripheral nodule cases. What we noticed in conjunction with that was that we were doing an increasing number of needle passes or instrument passes in the hopes of getting a positive call on R.O.S.E. And when it came time for us to take larger specimens, often with a cryoprobe, during our tool and lesion spin, we were noticing that, especially in cases where our R.O.S.E was not giving us a call, that our target lesion was becoming increasingly difficult to see. And this was a bigger issue with smaller targets. And this was mostly due to development of perilesional hemorrhage, sometimes atelectasis for very basilar and posterior nodules. And so we actually got into this challenging spot where the more we struggled to get an answer on R.O.S.E, the more instrument passes we did, and the harder it was for us to do a reliable cryobiopsy at the end of the procedure. Mm-hmm. And so the first thing we did was to remove R.O.S.E from our staging EBUS portion to sort of speed up the procedure, because we were losing so much time, spending a lot of time trying to get a R.O.S.E call. And when we started doing robotic cases, we just reduced the number of needle passes that we would allow ourselves to do, or the amount of time we would devote to R.O.S.E, because at some point we would just say to ourselves, we're not getting a definitive answer. Let's move on to getting a nice big cryobiopsy piece and move the case forward. All sort of leading to a point where we said, you know what if we just give up R.O.S.E altogether? And at that point, we really switched to doing cryobiopsies up front without on-site cytology. We did a few touch prep cases, but we gave that up as well. And what we found really was that not very much changed overall in our cases, other than that our days sped up a little bit.
That's amazing to hear. When you say your days sped up a little bit, any thoughts, estimates on how much time it cut down for a standard case?
Yeah. So the actual amount of time during the procedure did not change substantially, and we're actually looking at this data right now. So altogether, it looks like abandoning R.O.S.E shaved probably about 10 minutes or so off of the procedure. But that's exclusively in the amount of time that we were doing the case. It does not include the amount of time that we, for example, waited for our cytopathology technician to arrive in the room. Mm-hmm. And but you figure, we would do, between 4 and 5 nav bronchs a day. Shaving 10 minutes off of each case gives you time to do a whole other case potentially during that day. And so it significantly, over the course of a whole day, actually added up to a significant reduction in time. Other things that we're seeing just in a preliminary look at our, pre-ROSE, our yes-ROSE data as compared to our, post-ROSE data, the number of TBNAs and the number of actually instrument passes overall we did went down substantially. So we used to do TBNA for, over 85% of our cases. And when we got rid of ROSE, we did only for about 60% of our cases because we were doing cryobiopsies up front, prioritizing larger tissue specimens. And conversely, our number of cases that we would actually successfully complete cryobiopsy on went up. And although we haven't drilled down on this too much, what I suspect, based on what we saw in our sort of transition from using ROSE to abandoning it, was that we weren't doing as many cryos in the ROSE era because we would do so many FNAs and we would maybe lose clear margins on our smaller targets. And so, and all of this went with no change in diagnostic yield. In the 50 cases that I've analyzed so far, at the end of our ROSE era, we were around 85%. And afterwards, the next 50 cases without ROSE, 89%, probably not a significant difference. So, and then looking at all of our fluoro data and everything else, absolutely no changes. So what happened? We did fewer needle passes. We did fewer instrument passes overall. Our case time went down a little bit. And our diagnostic yield was not impacted. And so really all the things that I think the ROSE literature that we kind of reference and we talk about for, pre-EBUS lymph node biopsies all the way through, EBUS lymph node biopsies was kind of turned on its head in at least in the peripheral world with imaging guidance.
Mm-hmm. So I find this fascinating. Thus far, at least in the short time I've been in independent clinical practice after training, it's been pretty much dogma that ROSE is good. We absolutely need ROSE, and this is very against the grain. So you told me all the good things that you like about this workflow. There have to be some downsides, and I'd love to pick your head about those.
I think that, so I think where I practice right now and the way our workflow has changed, I truly do not think there have been downsides. I can imagine a lot of scenarios where there would be, and sort of thinking to different people's practice environments. For example, you and I both, spent time at the Cleveland Clinic where they have a real life cytologist outside the looking at your specimens. And that gives you really valuable data that you can bring back to the patient at the end of the procedure. Now, this is not the case everywhere.
Sure.
At my institution, we had a cytotechnologist in the room. They were sort of teleconferencing in with a cytologist. And I think in general, they maintained a somewhat higher, stricter threshold to make a call. And so, again, this is institution specific, but if you're practicing somewhere where there's a very high level of confidence in the ROSE outcome, and your cytologists are more willing to give you definitive information, it gives you that nugget of material to bring back to the patient and at least provide a little bit of closure at the end of the day. So I think that's something that you could lose out on. The other thing, and I think that in preparing to talk to you, I was looking at those recent guidelines that came out in CHEST. I think from earlier this year on acquisition and handling of EBUS samples, where they recommend using ROSE. Another situation is where you're doing your lymph node biopsies first. In cases where you're doing peripheral nodule biopsies, I think this is tricky because I think that you and I, we've sort of grown up in this shifting environment where there was this debate about whether to do the nodule or the lymph nodes first. And I think as people have become more aware of CT body divergence, the challenges of keeping someone under general anesthesia for a prolonged time where the geometry of the lung changes and maybe the success of your biopsy might go down the more time they spend on under anesthesia, I think that dogma has shifted a little bit. And I think a lot of us, if we go into a case suspecting we'll have to biopsy the nodule, I think a lot of people now go for the nodule first and do their staging later. But certainly in cases where you think there's a high likelihood your lymph nodes are going to be positive, then absolutely it might make sense to do R.O.S E. But I think that's still all in the context of whether it's actually saving you time. And I know that in our particular circumstance, that wasn't always the case.
I hear what you're saying. So I completely agree with you. Not all R.O.S E is the same. When I was in interventional pulmonary training, it was malignant, not malignant, or non-diagnostic, and that's the finest of detail I would get versus critical care fellowship, or now as an attending. Again, we have cytopathologists. I'm lucky to have them who look at the slides and give me some more granular information about what this is. And I found that having that information and being able to at least guide some conversations post-procedure with the patient has been helpful, especially in situations such as, hey, if the cytopathologist says, I'm pretty sure this is small cell. Going into it, we have some clinical and radiographic clues, but with some tissue clues, albeit it's R.O.S E, so we don't have the 100% picture yet. It allows me to kind of expedite some referrals and things like that. But I hear what you're saying, that not all R.O.S E is equal. So I'm going to push you here a little bit. If you had a cytopathologist reading the slides at your shop, would that change your approach, or you're pretty set in with your ways and like that workflow you got?
I think the last point you bring up is absolutely critical, and I think is one of the most challenging pieces to overcome. So, in an ideal world where there's exceptionally high concordance between the R.O.S E read and the final read, and there's data out there, including some that you yourself have furnished and put out there into the literature, that sort of question, bring the concordance or bring to light some of the variability in concordance between R.O.S E read and final pathology. But in a perfect world where that agreement is very high, I do think I would consider it for some of my cases. But then again, I would really want to make sure that truly sped up the process in the end, and that the denominator, rate limiting factor in the process wasn't downstream to my biopsy. For example, if I had a R.O.S E read that had high concordance with final pathology, would that truly result in patients getting to their SBRT or getting to their resection or their chemotherapy earlier? I think if anything that can speed up that patient's journey, through their continuum from diagnosis to treatment, anything that speeds that process up is worth incorporating into practice. I'm just not sure in the current environment where we are putting greater emphasis and seeing greater value in image-guided bronchoscopy, that's really going to hold true for R.O.S E.
Got it. So we're gonna fast forward a bit in the procedure that you're doing now. So let's imagine that you've done this peripheral sampling of this nodule, you did your cryobiopsies, got some good pieces, and then you're going to go to the next step, the staging EBUS. With no R.O.S E there, how are you handling with the decision of, do I switch needles and things like that, keeping in mind the latest TNM9 guidelines or criteria?
Yeah, we still do contralateral to ipsilateral staging process. We go through all of our nodes. We don't switch needles. Whether I need to reevaluate that and change that over time, I don't know. But fortunately, I'm in a group with three other folks, and we all kind of practice similarly, and we also all talk about these things and put our heads together about how we might change that process. The reality is that switching needles, I don't know how essential that is, as long as you're going in a systematic way and you're making sure not to upstage people. On the other side of it, oftentimes, if you got a positive answer on R.O.S E, you would stop your staging there. And so, information about the subsequent, as you get closer to the target or, skip areas, you sort of lose that information if you're terminating your EBUS early based on your R.O.S E result. I don't find that not using R.O.S E has changed my practice very much. And there were many cases, again, based on low confidence from R.O.S E where I am, or concerns about discordance, where we would complete our staging EBUS even if we got, an atypical read somewhere in, early on or in the middle.
Gotcha. I'm curious here. So at your shop, when you're doing, let's just say this is a diagnostic EBUS for someone who has lymphadenopathy and not a nodule or a peripheral lesion that you're chasing, and you're getting samples, it could be one of many things. You're putting those samples into RPMI for all cases, Cytolite, something else, or a mix of both. And I'll explain why I asked that question once I hear your answer.
So I'm so glad you asked that, because this is another place where I think R.O.S.E did us dirty a little bit.
Uh-huh.
When we used R.O.S.E and cases would take a longer period of time, oftentimes the time that passed from acquiring a specimen, that very first specimen, to finishing the case, to the samples going back to the lab, if they were stored in anything but formalin, they would get back to the lab and there would be some degree of degradation or some cell lysis, over the course of a couple of hours. And so we would have to make that decision in the room about whether to place it all in formalin, place some in formalin, put some in RPMI. We're very fortunate in that our lab will we put in an order for RPMI, and they'll do it once it gets back to the lab. We don't have the tubes brought to our Bronx suite or available in our Bronx suite. We basically leave everything in saline at this point, and the case time has gone down sufficiently, and the amount of time it takes that specimen to go to the lab, we've actually gotten positive feedback from our cytologists saying that something must have changed in our practice, that they're seeing much more viable cellularity, and the specimens were looking better. And it was really all because the amount of time from acquiring them to sending them off was a lot shorter. And so the ones that stayed in saline were not showing signs of degradation or lysis by the time they got to the lab and were processed.
Any differences in that approach when you're dealing with someone that moderate pretest, a high pretest probability of a lymphoma, a couple passes into RPMI as well, I'm guessing, or everything's in saline?
Everything's in saline, and the lab aliquots it out. Now, what I'll say is that for, another thing that sort of changed is that as our EBUSs have gotten faster, because we're not sending pass after pass after, so stepping back, when you have R.O.S.E, there is the inherent compulsion that I think we all feel for getting an answer.
Mm-hmm.
And even if the literature doesn't support that, your overall, the final diagnosis, the final result of the procedure is, reaches a plateau after a certain number of specimens, we will well exceed the number of biopsies just to get some positive reinforcement in the room from the cytotech or the cytologist. If you take that out of the equation and you're saying to yourself, okay, you're going to do 3 passes, it's super quick. And then what's to stop you doing an intranodal cryobiopsy as your 4th or 5th pass?
Sure.
And saying that to the lab. And then you not only have your specimen for, looking for lymphoma, but you also have the preserved architecture, which we know from studies is so valuable in differentiating, new diagnosis of lymphoma, looking at granulomatous processes, for example, sarcoidosis that can be a little trickier to get just on FNAs. And so we shifted our practice in other directions to try to, make sure that we weren't just removing something, that we were actually adding value to these cases. And we still will, if I'm just doing FNAs and, I have a high suspicion for lymphoma, I'll order, for some of that specimen to go in RPMI. We still do that.
So you mentioned the use of the cryoprobe, and you're relying more and more on it. Are you using needles at all for your peripheral samples, or is it just straight to cryoprobe?
It's straight to cryoprobe unless we can't penetrate into it without making a needle tract first. So, again, going back to the things that, all of the sort of classic R.O.S.E literature talks to us about. One of the recurring mantras is, fewer biopsies, fewer passes, and then maybe associated with a decreased, risk of, decreased complications. What at least we've found is that abandoning R.O.S.E has actually resulted in fewer needle passes and less instrumentation. And again, someone can come back and say, yeah, but you can get the best of both worlds. You can do a cryobiopsy and touch prep. That's a completely legitimate way to do it. And I think that has value in certain settings, but we personally don't do it. And we were therefore able to get rid of FNAs because they serve no additional purpose. I will do FNAs if I'm sending stuff to micro, because sometimes they like that more, but otherwise I won't.
And Brian, before we wrap up, is there anything else about this topic that you feel we missed and we should have covered for our listeners?
I mean, something that I think about and sort of comes up, and something that my group thought about that I had never really entertained was, and then something that we talked before before this, but congratulations to you and your group on Veritas. But something that you even bring up in the Veritas study is how often we use R.O.S.E versus other people who are working in a similar space. In the study that you were part of, 96% of the bronchoscopic biopsies, the bronchoscopic cases used R.O.S.E. 7% of the TTNAs did. And so one of the questions we asked ourselves was that, the people who are historically most successful at doing, at least for peripheral, doing peripheral lung nodule biopsies, almost never use R.O.S.E. And why is that the case? And really thinking about, the gold standard, transthoracic biopsy, and, maybe not after your study, the gold standard for that much longer, but why do we use it and they don't? And just sort of thinking and, putting it into perspective and thinking about where does our workflow fit into what everyone else is doing to address the same kinds of problems.
Brian, this was fantastic. I think you gave myself and our listeners a lot to think about, and hopefully it doesn't turn into a surplus of people tossing their microscopes. We really appreciate your time.
Thank you so much. And, I really appreciate talking to you about this. The thing that gave me a little knot in my stomach going into this was that I don't want to say things that are, a disparagement to all of the incredible cytologists that work with us. We're just giving them, on the other side of this, we're able to do more cases now. We're giving them more specimens to look, and we obviously can't do their work with, our work without them. It's just whether we see them in the room or not. And so I never want this to be taken as, a disparagement to them, but thank you again so much for having me and for talking about this.
Absolutely. Thanks, Brian.